the presentation about nursing documentation, the basic rules of it. It's just a brief little overview of some basic concepts you need to know about nursing documentation. Nursing documentation is very, very important. It's a very important part of what we do. It's how we communicate with other disciplines. It's how we communicate with other nurses. It's how we make a written record or a documented record, a computerized documentation record in some cases, of what our care was and how we can recall that care in years if we have some issues, legal issues that we need to be able to defend, or if the hospital needs to go back and look at a case and see what's going on. Our documentation is very, very important with regard to that. How you document is critical. Realize that the case may come up, if it's a legal case, in years away from now, not in such that you'll remember it, actually, usually. It's been my experience that things that come up are typically not patients that you really remember. The patients that you think are going to be, certainly something's going to come of this, I need to remember this patient. You a lot of times never hear anything from that, but then the patient that has a complaint or some random problem comes up, it's a lot of times somebody you really just don't remember. So it's important that you document very, very well. You need to type or write neatly and legibly. Your handwriting and your spelling reflect who you are to the people that are looking at your documentation. So if your documentation is messy or your spelling is inaccurate, it's not a really good reflection on you. If your grammar is incorrect, once again, that's not a very good reflection on you. Typically, the hospital has a rule to write with a particular color of ink. Typically it's black ink. This says blue or black, but you really have to go with the policy of the hospital. Blue does not photocopy very well. Certainly red or green doesn't photocopy very well. Military time typically is what we use on documentation for the hospital. There are authorized abbreviations that you can use. You can't just make up your own abbreviations. There is somewhere in your policy and procedure a list of approved abbreviations. Sometimes it just refers to a particular text or a particular nursing document, but you need to make sure that you're using abbreviations that are appropriate to your institution. If in doubt, just don't abbreviate. When you transcribe orders, this is if you're given an order by a physician, if you have a written order from a physician and it's your responsibility to put it into the chart, then you just need to be sure that you transcribe those orders very accurately, exactly what the physician writes. If the physician leaves out a piece of the order, it's your responsibility to contact that physician and clarify that order. Don't ever transcribe an order that you don't understand. In computerized charting, many times it's the pharmacy's responsibility to put it into the computer depending on what sort of situation you're in. But once again, it's your responsibility to compare the doctor's order to the transcribed order, because you are the last person to see that order before you actually give it to the patient. So it's your responsibility to have the nursing staff responsibility to have looked at the doctor's orders and compared them to the MAR before it's approved to be given to the patient. Document complete information about your medications. Don't leave out your route or your dose or your time or any of the rights that we know we need to chart. Chart promptly when you give a medication or when you perform a procedure. You need to chart promptly so you can chart accurately. You don't ever know what's going to happen once you walk out of that room. If you say, well, I'll just chart this later, you may or may not get back to chart that. And when you do get back to chart it, you may or may not be able to accurately reflect what went on in the situation. So never chart your nursing care ahead of time. Never chart. If you know somebody's going to be on oxygen O2 at 2 liters per nasal cannula all night long and you plan on charting that every 2 hours, you cannot sit down at midnight and chart O2 2 liters per nasal cannula at 12 and 2 and 4 and 6. You have to wait to each of those 2-hour intervals, walk into the room, visualize that oxygen going at 2 liters on that patient's face, and then you document it. You never document ahead of time. Even things like IV fluids. If your patient has normal saline going at 75 cc's an hour and you know it's going to go on all night and you're going to have to document it all night long, you don't document that until the time that you actually walk into the patient's room. You see that normal saline going at 75 cc's an hour at midnight, for example, and you chart it at midnight. And then you go back at 2 and you see it going at 75 cc's an hour into the patient's arm at 2. You chart it at 2. You don't go ahead at midnight and chart your midnight and your 2 o'clock and your 4 o'clock and your 6 o'clock for that IV fluid. Clearly identify care given by another member of the healthcare team. Don't chart patient ambulated 20 feet in the hall, period, if you were not the one that did it. If physical therapy did it, then you chart patient ambulated 20 feet in the hall per physical therapy, because you need to identify who was with the patient, and if you don't, the assumption is that it was you because you're charting it. Well, if it wasn't you, then that is inaccurate charting. That's falsifying your record. Okay. If you're charting on a narrative form, don't leave blank spaces where someone can come in and document behind you and make it look like you put something wacky in there. If you forget to document something on a narrative form and you need to go back and document it, make sure that you designate on the narrative form that it is a late entry. And different hospitals have different ways of doing that, but you can put the time and then in parentheses put late entry underneath it to designate why you charted at a 10 a.m. Assessment at 2 p.m. You just put late entry around it. So correct mistaken entries properly. Hospitals, once again, have different policies for that, but typically you just put one line through it. Some places they'll want you to put your initials, but you don't write mistaken entry, wrong chart, so on and so on and so on. You don't want to put something that says wrong in there, because that's sort of a red flag for the legal eagles. Oh, you did something wrong. It says right here, you did wrong chart, wrong patient. You did something wrong. So you just one line through it and initial it. You never scribble it out so somebody can't see what's under it, because that's suspicious looking. Just one single line. You certainly never use whiteout. Don't sound tentative. Say what you mean. Don't say patient appears sad, or patient might be having chest pain, or whatever. You just document exactly what you see. You don't have to document what your assumptions are about that. You can just write exactly what you see and let the reader decide at that point, based on what you documented and what you did about it, what you were thinking. But you don't sound tentative like, well, maybe this patient's got this going on, or maybe this patient's got that going on. That's not appropriate. Don't tamper with medical records. Do not go in and change someone else's documentation under any circumstance for any reason. Computerized charting won't even let you do that. It will let you go back and modify your own charting. However, it will timestamp when you did what. So it's easy to go back and see what your original documentation was and then go back and see what you changed. Don't criticize other healthcare professionals in the chart. Don't say, patient states bad care was given on night shift. I reassured him that that's always the case, it's just not him, or something like that. You don't criticize other healthcare professionals in the chart. You don't say, I called the doctor and told the doctor such and such and so, and he refused to do anything. You can just simply document, Dr. So-and-so notified of blah, 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 whatever it is you're calling about, no orders noted. If what you did was go beyond that doctor and go to the medical supervisor or whoever, because you were concerned about that, or you went to your house supervisor and voiced concerns to the house supervisor what the doctor ordered, you're not going to chart. House supervisor informed that doctor refused to take care of the patient, so and so and so and so. Okay, you can simply write Dr. So and so informed of blah blah blah, No orders noted, house supervisor notified. You don't have to go down the road of why I had to notify the house supervisor and all that. You don't want to blatantly criticize other healthcare professionals in the chart because it sets us up for liability. Okay. Any patient that or family member that makes a comment regarding suicide, it's very, very important that that is documented in the chart. Suicide is something that we're always screening for, we're always looking for. Even in patients that's not what they're in there for, we're still always looking for that. So you need to make sure that you look at that. Eliminate bias from typed or written descriptions of the patient. Don't say, oh, happy little old man sitting on the bedside, because number one, it's you're saying that he's happy. You don't know if he's happy. He may be smiling. You could say, you know, little old man sounds like he's cute. Well, that's your opinion. You're just going to say smiling elderly male on the bedside or something like that. Precisely document any information that you report to the doctor. You don't want to say, Dr. So-and-so called, notified of elevated sodium. You want to say, Dr. So-and-so called, notified of sodium level of 161 or something. If you have a situation and you think that the patient may have contributed to whatever the problem is, you just very matter-of-factly document exactly what you saw. Patient fell out of the bed, and you went in there and he smelled strongly of alcohol. He had, and you had found a bottle of alcohol on the windowsill outside where he was hiding it. So what you're going to write is you know, a pint of whatever it is, noted on outside the windowsill, patient informed he was not to have this in the room, family notified that the bottle will be in the nurse's station. And then you come back in and you find him on the floor, and you simply document what you found: strong odor of alcohol on breath or something like that. So you're not saying the guy got drunk and fell out of the bed. What you're saying is, this is what I found, and then this is what I found, and then this is what I smelled on him. Okay? Very matter of fact. Avoid using labels to describe your patient's behavior. Once again, don't say he's happy. You can say he's smiling, or you can say he states he's happy, but don't label these people. Don't refer to staffing problems. Patient unable to be seen on Q1 hour rounds because we don't have the staffing to do so. That would not be appropriate to put into the chart. Refrain from mentioning that an incident report had been filed. If somebody has some sort of maybe a medication error and you gave them some Tylenol and they weren't supposed to get any Tylenol, you just write Tylenol 650 milligrams PO given, and then Dr. Jones notified, because you have to call the doctor and tell him I gave the wrong pill. But what you don't want to say is Dr. Jones notified of wrong medicine given, because there's that wrong word again. So you just matter-of-factly, you gave it, you called the doctor, no new orders, or new orders given, or whatever the situation was. Okay, you will make out an incident report. You don't put that in your medical record, because that will be pulled into court, into your legal record, if you mention it in the documentation. The incident reports is for the hospital, it's for quality assurance, it is not for a legal record. Okay. Don't try to explain a mistake or use words like accidentally or somehow. Somehow I gave this patient Tylenol 650 milligrams, or Tylenol 650 milligrams given accidentally. Just say what you did. Don't use all those other qualifiers in it. Avoid airing your dirty laundry. Once again, patient complains of care on night shift. You know, patient informed, night shift nurse stinks. Not a good nurse, or whatever. Never chart you informed a colleague of a certain event if you only mentioned it, meaning if you're just standing in the hall and Dr. So-and-so is down at the other end, you go, hey, Dr. So-and-so, did you see Mr. So-and-so's sodium level? That's not informing him that the sodium level was elevated. That is passing him in the hall and saying, hey, did you see somebody's sodium level? So that's not that you informed them officially. Okay. You need to make sure that you informed them of exactly what it was and discerned if they want to give you any orders or not. Interpretation of data should be supported by descriptions of specific observations. This goes back to, you don't want to say what you think is going on. You want to say what exactly you see. And then however that's interpreted, this is what you see, this is what you did, this was the result. However that's interpreted is based on the actual objective observations. Okay, not because you said it was what was happening. Okay, documentation should be clear and concise and specific. Don't use vague terms. Don't use good, fair, moderate, normal. Those should be avoided. You say exactly what you see. You don't say their skin looks good. Their skin is pink and warm and dry and intact. Okay. Other generalizations. Avoid expressions such as status unchanged. Basically that means it doesn't sound like you really looked at the patient. Assessment done. Well, we know you're in there doing an assessment. What did you see? What did you find? Had a good day. The only time I would use that is if the patient maybe said that. But we don't know what a good day is. Slept well. Well, what does that mean? What you did is you went in and you saw him every 2 hours and he was resting and his respirations were regular and so on and so forth. That's what you need to document, not that he just slept well. Up and about, that's kind of, almost kind of flippant. Up and about sounds, like up where and doing what, doing about what. So you want to say ambulating in room without difficulty or something like that. Don't say appears or seems or apparently. That's too subjective. You want to say exactly what you mean. Do check that you're in the right chart. Do chart precautions or preventive measures every time you're supposed to. At the hospital, we document those fall preventions, those fall interventions every 2 hours. Either you or the tech or somebody is supposed to be charting those. So if you're doing it, then you need to chart it, because if that patient falls and you didn't chart it, it looks like you didn't do it. So if you are doing everything you can do to keep that person from falling, if you're doing all those fall interventions and they still fall, at least when you get in court, if they're going to be able to say, I was doing everything I was required to do and everything that was reasonable to do for this patient, and they still fail. So chart patient refusal of treatments or medications. If somebody refuses their fall monitor, then you need to chart that they refuse their fall monitor. If they're refusing medications, you need to chart that they refuse medications. You also need to chart that you notify the physician of this refusal. Okay. Don't write imprecise descriptions, bed soaked, large amounts. You want to be more specific than that. Don't give excuses, medications not given because not available. Just chart medications not given. Don't chart what someone else said, heard, felt, or smelled. So don't, if the tech tells you the stool smelled like it was a GI bleed, but you didn't actually see it and you didn't actually smell it, then you're not going to chart stool smells like a GI bleed. Okay. The tech can chart that in their charting, okay, because they're actually the one that saw it. Correcting errors. Draw one straight line through and end to correct a right error above it. Once again, you need to look and make sure what your policy is about that, because I think at East Alabama we don't write error. I think we just put our initials above it. But you need to be sure and initial and date it. Never use whiteout, erase, or obliterate an entry in the individual's record. So never scribble it out. Okay. Late entries may be entered at a later time, and they should specifically say late entry. Don't use patient in your charting. Everything is supposed to be about the patient anyway. Patient was laying in bed, blah, blah, blah. Just write laying in bed. Don't list their age or their sex. Don't write incomplete sentences. All of that are just extra words. They know, you know it's about this patient because it's in their chart. So we know what their age and their sex is. Now it may be a little bit different if you're writing like a history and physical or something like that, and then you may see, you know, 32-year-old white female, da da da. But in general, just your regular narrative, you can just write, you know, the patient sitting on the side of the bed. Okay. Don't write incomplete sentences. Oh, I said that, sorry. Sign each entry. Every single time you sign something, you need to sign it with your name and your title. Okay, however they do that. Now, the computer, it's already signed for you because you logged in. So, and don't write over entries. Don't, like, slip some words in there right above it or something that you forgot to put in there. Okay. Cutting and pasting from previous notes without editing and updating is not permitted. Using other providers' observations or assessments is unethical and unprofessional. Meaning, just because somebody wrote that their lungs were clear 4 hours ago at 6 a.m. and here it is your 10 a.m. assessment, or it was, you know, then, and you just write clear because they wrote clear, or you just wrote unchanged, or so on and so forth. You need to do your assessment and you need to document what you see every time. Okay. Golden rule of documentation. You'll hear this a million times in nursing. If you didn't document it, you didn't do it. If it ain't wrote down, it didn't happen. Okay. The way it was wrote down is the way it happened, regardless of the way it happened. So, I don't know. That's cute, but anyway, the golden rule of documentation is if you didn't document it, you didn't do it. And if you did document it, the way you documented it is the way it was as far as the court sees it when they pull that chart in a few years for you to have to defend what happened. So please be sure you're always thinking about the importance of documentation. Is it more important than patient care? Of course not. Is it just as important as patient care? We need to make sure that we do good, thorough patient care, and we also do good, effective charting.